పెట్టేసి లేకపోతే మానేసి పర్వాలేదు, ఎలాగైనా పర్వాలేదు. Okay, thank you. Morning, everybody. Sorry we are delayed today because there is a problem with the net and everything. We have been talking about actually the ocular manifestations of systemic disorders. We have covered, I think, female sex hormones which cause actually retinal and venous thrombosis, papilledema, ocular palsies with diplopia, nystagmus, optic neuritis with optic atrophy, retinal vasculitis can also occur, scotomas can occur, migraine, and cycloplegia and macular edema. All these things they occur because of the female sex hormones. Chloramphenicol actually, which was used previously as a for the treatment of typhoid fever when we were children, actually is sparingly used nowadays. We don't use it regularly, and it may cause actually an optic neuritis and an optic atrophy. Streptomycin, it causes optic neuritis. Tetracyclines, it can cause actually pseudotumor cerebri. And anti-malarials, we have discussed, I think, the chloroquine, which is used for treatment of malaria and also in rheumatoid arthritis. Sometimes we use it, and it can cause actually bullseye maculopathy, central scotoma, and pigmentary degeneration of the retina. And chloroquine keratopathy can also occur, atosis can occur, and electroretinographic depression occurs with the toxicity of chloroquine. Sulfonamides, so they cause Stevens-Johnson syndrome. It causes an acute condition where actually you see the ulceration of actually the conjunctiva and also the lids. It's because of the allergic manifestation of the sulfonamides and some other drugs also. Ethambutol, which is used for tuberculosis, optic neuritis can occur, and atrophy also can occur. Isoniazid and that drug which we use for tuberculosis, optic neuritis and optic atrophy can occur. Chelating agents such as penicillamine, actually it can cause ocular pemphigoid, ocular neuritis, and ocular myasthenia. Vitamin A, we have already talked about it, and if it is in excess, actually papilledema, retinal hemorrhages, loss of eyebrows, and eyelashes. Metarosis, that's what we call it, and nystagmus and diplopia, all these things can occur. And vitamin D, band-shaped keratopathy can occur. Anti-rheumatic agents such as salicylates may cause actually nystagmus and retinal hemorrhages. Indomethacin, some is usually, very rarely, it causes corneal deposits. Phenylbutazone, it can cause actually retinal hemorrhages, both superficial and deep. Categories of systemic disorders: congenital, vascular, endocrine, autoimmune, idiopathic, infectious, drugs and toxins, and neoplastic, and trauma, all these things. So we have also seen actually for every patient who comes with who is referred to us on examination of having a systemic disease, the physician feels that actually he has got, he can have an ocular manifestations of a particular systemic disease. So we may refer the case to us, and sometimes actually when we examine routinely our patients, so we see certain findings which are suggestive of certain systemic disorders, and we refer the patient actually to the physician to look into our point of view that the patient may have actually the particular systemic disorder because he has got this sort of ocular findings. So every patient who comes to us for after referral or whenever we do examination routinely, a vision must be tested for every individual, vision unaided, vision with pinhole, vision with previously if he has got glasses with glasses. And you look at the lids and also make sure that every lid is absolutely normal. There is no entropion, or eyelashes. There is loss of eyelashes and all these things. Pupils must be examined for any abnormality pupil, relative apparent pupillary defect you should see, and pupillary reaction whether they are brisk or not also you will have to mention. And motility of the eyeball, extraocular movements in all the directions you will have to see. And examination of the anterior segment with slit lamp biomicroscope. That's important. And dilated ophthalmoscopy, both with the direct or 90D or direct ophthalmoscope with the sclerotic preserve. You will have to examine the retina and also the periphery varacity of the retina and the optic nerves, and also the blood vessels also will have to examine in the fundoscopy. Visual fields, either by confrontation technique or by actually Humphrey's visual field analyzer, you will have to take the visual fields of the individual, the defects of which actually can be telltale sign of actually one of the systemic disorders, an intracerebral tumor. All these things can be can reflect as loss of visual field in the individuals. So the congenital disorders with ocular manifestations, I think we have already seen Down syndrome, Marfan syndrome, myotonic dystrophy, tuberous sclerosis, congenital metabolic disorders, and neurofibromatosis, all these things. This is Marfan syndrome, where actually you have a subluxated lens. This is a lens border, what we see, and this is a phakic area, and this is the phakic area. This is actually myotonic dystrophy, where you see the corneal deposits and also the cataract. So this is neurofibromatosis, coffee-only spots on the abdomen of the individual, and also you see here actually leech nodules, so which is suggestive of actually neurofibromatosis, von Recklinghausen's disease. Hypertension, migraine, and emboli and amaurosis fugax, actually these things, they have their own ocular manifestations. Vascular disorders. So vascular hypertension, we have already seen affects the eye the same way as it affects the rest of the body, rest of the arteries in the body. Arteriosclerosis and direct pressure damage can also occur in these cases. It's actually hypertension is the #1 predisposing factor for central retinal vein occlusion and branch retinal vein occlusion. In a normal eye, actually, the vessel walls are transparent and you see the blood through it. Okay, arteriosclerosis causes thickening of the blood vessel wall, and early sclerosis, it appears as a copper wire appearance, and the more sclerosis or late sclerosis, actually it will appear as silver wire appearance. Okay, arteries and veins, they share the same sheet. An arterial wall sclerose and thicken. The vein is compressed, and AV nicking can occur as the earliest manifestation of vascular hypertensive retinopathy. So acutely elevated blood pressure can lead to fibrinous necrosis of the blood vessels. You see actually get hard exudates, cotton wool spots, and also hemorrhages, superficial hemorrhages mostly. And in grade 4 hypertension, we can see macular edema and also the optic nerve edema. So this is actually a picture of hypertensive retinopathy, and this is also hypertensive retinopathy, and this is grade 4 hypertensive retinopathy with papillary edema. And vascular hypertension, classically, it is taught that hypertensive should be referred for ophthalmological checkup. Actually, usually in case of toxemia for the pregnancy or hypertension induced during pregnancy, those ladies and also the people with hypertension, routine hypertension, they are sent to the ophthalmologist with a request to verify the fundus examination. Especially in toxemias of the pregnancy, suppose if the patient has got actually papillary edema, they may terminate the pregnancy during that period. Otherwise, it becomes fatal both for the children and also both for the child and also the mother. The mother may lose the eyes, vision, and the child actually may be precarious before the delivery. Okay. So the main idea in case of hypertensive retinopathy is to reduce the to reduce the blood pressure. That's the what we'll have to do. As an ophthalmologist, we cannot do anything regarding the findings in the retina. Okay, so if the blood pressure is reduced and it's maintained at normal, the changes may come back to normal after some time. Okay, suppose if the systolic blood pressure is more than 200, refer the patient to ER, emergency room. Migraines, they are known as vasospastic phenomenon and usually affects the temporarily, but they can be permanent like a stroke. So vascular migraines, actually the ocular manifestations are scintillations, transient homonymous hemifield analysis, hemifield loss, and transient cortical visual loss. Amaurosis fugax can occur, and rarely a central retinal artery occlusion or branch retinal artery occlusion also can occur. Treatment is actually prevent frequent attacks, examine for visual loss, and consider discontinuation of oral contraceptives in case they is later. There are a lot of vascular emboli which can cause actually the difficulty in vision. Usually these emboli are atherosclerotic or cholesterol emboli from the carotids. So the sources can be either heart and heart valves, and in case of IV drug abuses, so Talc Emboli can also occur. So they manifest usually the embolization of the central retinal artery or branch retinal artery. It may actually manifest as an acute visual loss, and the diagnosis usually we make on in such kind of cases is central retinal artery occlusion or branch retinal artery. So class alone answer. So this is actually a diagram depicting the various emboli. This is central retinal artery. And here actually you have an emboli, and ophthalmic. This is actually ophthalmic artery. You have an emboli, and this is internal carotid artery. So cholesterol embolus, you see the emboli here. Talc emboli, multiple, you see, and vascular amaurosis fugax. Amaurosis fugax actually is nothing but sudden painless monocular loss of vision. Usually it manifests as though the window is coming down, shut down before the eyes. Okay, by definition, vision returns to normal within few minutes. It's caused by temporary arterial occlusion. Vascular blood dyscrasias, hyperviscosity syndromes. There actually you see thrombosis, including polycythemia, myeloma, and leukemia cases. Thrombocytopenia, bleeding will occur. Anemia, ischemia can occur, including sickle cell anemia. And lymphomas also, we have various ocular manifestations. Hyperviscosity syndrome, and its effects on the retina. That's, here actually you see in leukemia, multiple superficial hemorrhages, and leukemia again, we have hard exudates and also the superficial hemorrhages, sometimes resolving hemorrhages, sickle cell anemia, and here again sickle cell retinopathy. So diabetes mellitus, I think we have already talked about it in detail. So the macular edema, proliferative diabetic retinopathy, this is what we see as neovascularization elsewhere and neovascularization over the days. Vitreous hemorrhage, and here actually you see subconjunctival hemorrhage and also the rubeosis iridis. We have the neovascularization of the iris here in case of proliferative diabetic retinopathy, we said. And here actually it's a tractional retinal detachment. So we do pan-retinal photocoagulation, scattered 1,000 to 3,000 laser burns actually throughout the retina we make it. We should avoid actually macula in these cases, and decreases retinal oxygen need, which decreases the impetus for neovascularization. And treatment needs to be, it's an ongoing treatment. Actually, the patient will have to come for follow-up almost every 3 months, and we'll have to examine the patient and see whether there are any new vessels. Again, we'll have to give anti-laser burns. PDR before this thing and after laser burns. So next, actually, I think last time we stopped here. Autoimmune disorders. There are another group of disorders where we see actually the ocular manifestations of these people. So there are different autoimmune disorders, connective tissue disease such as systemic lupus erythematosus, Sjogren's syndrome, ankylosing spondylitis, Graves disease, myasthenia gravis, rheumatoid arthritis, and giant cell arthritis. So all these things actually they can have ocular manifestations. So autoimmune connective tissue diseases. So dry eye are the most common manifestations. So the patient may have the symptoms such as burning, photophobia, they cannot look at the sun or light or something. A foreign body sensation can also occur in these individuals. So systemic lupus erythematosus, autoimmune disease, the patients may present with actually dry eyes, or they may have actually a red chanda eye, where we may diagnose actually scleritis, and peripheral corneal ulcers can also occur in this condition, and typical retinopathy in case of systemic lupus erythematosus can also occur. Optic neuropathy in the form of optic neuritis or retinal neuritis can also occur. So this is actually the funnest picture of actually systemic lupus erythematosus retinopathy. We see a lot of exudates, and hemorrhages will also be present. And optic neuropathy, where actually the margins, these margins, they are completely blurred. Disc edema is also there. So next one is Graves disease. Here actually the immune system attacks both the thyroid gland and also extraocular muscles. So it may not necessarily be related to the thyroid hormone levels. So though the thyroid is euthyroid, there can be actually Graves disease. So manifestations are the patient may present with a proptosis, lid retraction, and when actually the patient sleeps, in case the eye will not be closing completely because of the lid retraction, and they may have actually exposure keratitis or exposure keratopathy, and they may have strabismus, misaligned or malaligned eyes, and optic neuropathy can also occur in case of Graves disease. So this is a picture of actually Graves disease with proptosed eyes, bilateral. Here also it is in the picture. Here actually the cornea is dry and superficial punctate erosions are also there, which are actually inside. And this is actually a CT which shows actually the thickening of the retina muscle. And management of case of Graves disease is initially we give them the artificial tears. Oral steroids can also be given to reduce the inflammation. And suppose if the patient has got actually strabismus, depending upon the type of strabismus, we can do the surgery and align the eyes, which are actually malaligned or misaligned. And lid surgery, in case actually the patient has got a lid retraction, we can bring back actually the normal closure of actually the lids. And orbital decompression surgery, in case it is definitely threatening the optic nerve, and also definitely threatening actually the cornea. And in such cases, actually, we do the orbital decompression surgeries. And very rarely, we give orbital radiation to reduce actually the size of the orbit eye. So the next one is myasthenia gravis. So it's an autoimmune disease again, and it's a reaction to the acetylcholine receptors in the muscle tissue. Ocular manifestations are the patient may have ptosis, and they may have actually strabismus. Facial weakness is also reported, and once at the end of the day, fatigue, they fatigue easily. So initially, in the morning, when actually the patient gets up fresh, so the eyes may look normal. But as the day progresses on, and at the end of the day, there will be more ptosis. So here, this is a picture actually depicting ptosis, and it's a case of myasthenia gravis. And other manifestations which can occur in case of myasthenia gravis are proximal limb weakness, and these people, they may have difficulty in swallowing and also breathing, which can be fatal. And sometimes it is triggered by the myasthenia gravis is triggered by an underlying thymoma in the chest. Always we advise actually whenever we suspect a myasthenia gravis, we may advise actually CT chest to detect a thymoma. Okay. The diagnosis of myasthenia gravis is confirmed by hydrophonium or Denselan test and checking for acetylcholine receptor antibodies. The management is oral anticholinesterase, pyridostigmine, and steroids can be given, and immunosuppressive therapy can also be given, and surgical removal of thymoma in case if it is there on the chest, CT of the chest examination. So rheumatoid arthritis is another autoimmune disease where actually we will have a lot of ocular findings. One is the patient may present with actually dry eyes. The patient may have actually an episcleritis or scleritis, and corneal ulcerations can also occur in these individuals. And the patient may have uveitis, a granulomatous uveitis, most commonly seen in these conditions. So this is an episcleritis in case of rheumatoid arthritis, and this is scleritis in case of rheumatoid arthritis, and necrotizing scleritis. This is necrotizing scleritis, this area. Okay. And scleromalacia perforans, this is another complication actually we see in case of rheumatoid arthritis. And corneal ulcerations, peripheral corneal ulcerations, they are seen actually in case of rheumatoid arthritis. This is a peripheral corneal ulceration. So the management of the ocular findings in case of rheumatoid arthritis are first and foremost is we give artificial tears, and secondly we try to administer topical steroids to reduce the inflammation. Oral steroids can also be given, and immunosuppressive therapy is the final resort. And normally we take the help of a rheumatologist also in the management of ocular findings with rheumatoid arthritis. So juvenile rheumatoid arthritis is another autoimmune disease where you have a lot of ocular manifestations. The patient may have actually an asymptomatic iritis, and secondary cataracts and glaucoma can also occur in these individuals. The articular arthritis is quasi-articular, and rheumatoid factor is negative in these cases. Antinuclear antibodies will be positive. Idiopathic disorders with ocular manifestations such as sarcoidosis and multiple sclerosis, HLA-B27 associated disorders such as Reuters, ankylosing spondylitis, Behçet's disease, Behçet's granulomatosis, all these things they present with sometimes ocular manifestations. So idiopathic sarcoidosis, so usually this is a multi-system disorder, inflammatory disorder. It's a generalized one. About 25% of the people with sarcoidosis they may present with ocular manifestations. It's much more common in blacks and Hispanics than whites. Ocular manifestations are we see orbital and eyelid granulomas, and lacrimal gland infiltration causing dry eye can also be seen in these cases. And when you examine the patient, there can be actually the conjunctival nodules, and a granulomatous uveitis can occur. It's the most common manifestation in case of sarcoidosis. Iris nodules can also be seen, and retinopathy is also reported in case of sarcoidosis. So this is actually the mutton fat capies in case of granulomatous sarcoid uveitis. And sarcoid retinopathy, this is a picture. Treatment is actually we give topical steroids and also systemic steroids, and if they are not helping the patient, we may go and resort to actually immunosuppressive therapy. Infectious disease with ocular manifestations, we have HIV, AIDS, herpes zoster, candidiasis, syphilis, TB, Lyme's disease, and infectious HIV and AIDS ocular manifestations are the patient may present with actually a dry corpuscle sarcoma of the conjunctiva or eyelids can also occur. HIV retinopathies, cytomegalovirus infection, CMV retinitis can also occur. And so this is HIV retinopathy, picture of HIV retinopathy. And CMV retinitis, it is a leading cause of visual loss in case of AIDS. And about 25% of the AIDS patients, they become victims of actually CMV retinitis. And this CMV retinitis usually occurs when the CD4 count actually falls less than 50. And what we see is we see the actually hemorrhagic necrosis of the retina. It indicates poor prognosis for survival. But once actually CMV retinitis occurs, usually the lifespan of the individual is shortened. Okay. Fortunately, infrequently seen since advent of the protease inhibitors. So previously, it used to be more common after the advent of protease inhibitors. Actually, the onset of CMV retinitis has come down. Okay. So this is a CMV retinitis, the picture of CMV retinitis, and the treatment of CMV retinitis is intravitreal ganciclovir, intravitreal foscarnet, and intravenous ganciclovir, intravitreal venous foscarnet, and intravitreal ganciclovir can also be given. We have ganciclovir sustained release intravitreal implants, and they can also be implanted. In case of infectious herpes zoster ophthalmicus, in people actually who are having herpes zoster, about 10 to 15% of the individuals with herpes zoster actually affecting the sixth nerve. Okay, there can be actually ocular findings, and the tip of the nose is involved. Nearly about 40% of the people they may have actually ocular findings. Follows eye is often involved, roughly in about 5 to 10% of the cases. So prevalence increases with age. In patients under 40 years, always suspect HIV, and in patients where actually very rarely herpes zoster can be bilateral, in such cases you suspect HIV. So what we see here actually is painful crusty vesicular lesions along the distribution of the nerve. And examination of the eyes reveals actually corneal stromal keratitis, and sometimes corneal melting can also occur, and uveitis can occur, retinitis can occur, and neuritis can also occur. So this is a picture of actually the herpes zoster ophthalmicus. This is in the picture which we see where we see actually herpes zoster ophthalmicus. The management is oral acyclovir, 800 milligrams. 5 times per day or intravenous can be given. It should be started within 7 days of the onset of the symptoms, and it should be continued for about 10 days. And when eye is involved with various manifestations, topical steroids should be given. Lubrications can also be given. So that's actually in brief about the ocular manifestations of systemic disorders. Okay. Next, I think we have some time. with that, actually, we finish ocular manifestations of systemic disorders. I think we'll go on to the ocular therapeutics. 1 minute, I'll call those people to tell. Giri. Smart is by Jiva Mandi. Topic happen about topic kavali. Ocular therapeutics. Start just outline. CD contents ocular therapeutics and meet ophthalmic ocular therapeutics and other sections. Ocular therapeutics. Ocular.
Yes.
My 71 KB 85 slides, ma'am.
PDF.
PDF format. Laptop, I don't know. Automatically close it. ఎలా చేయాలి? So next, actually, in the examination, especially in the orals, what we do is we keep some drugs. So maybe an antibiotic, maybe a cycloplegic, maybe a simple dilator, pupillary dilator, maybe actually a anti-glaucoma medication. And we ask you to actually to speak about it, to tell us actually what exactly the drug is, what it contains, concentration of it, and also the mechanism of action, side effects, and the doses. All these things actually we ask in the examination. So in that point of view, actually, it is very, very important for you people to know about the ocular therapeutics. Though we have covered most of the time while talking different topics, I thought actually it is wise to rather brief you up about regarding ocular therapeutics in another class. So the pharmacodynamics, they deal with actually biological activity and clinical effects of the drug. If the drug is working at the receptor level, it can be an agonist or an antagonist. If the drug is working at the enzyme level, either it can be an activator or inhibitor. So the pharmacokinetics, they deal with actually the absorption, distribution, metabolism, and excretion of the drug. So the drugs can be delivered to the ocular tissue as locally in the form of eye drops or eye ointments, and periocular injections such as subconjunctival injection, subtenon injection, posterior subtenon injection, peribulbar injections, and retrobulbar injections, all these things. And intraocular injections, intravitreal, actually, we give the injections. And systemically, the drugs can be given as oral tablets and also intravenous injections. Okay. So, so if we take about actually the tear film, under normal circumstances, the volume of the tear film is around 5 to 7 microliters. With the normal rate of secretion of tear film is about 1 to 2 microliters per minute. So when you add a drop of medication, actually it causes the eye, causes increased blinking of the eye, and and also squeezing, which propels actually the drug towards the lacrimal sac. Then the drug passes on to lacrimal sac, and from lacrimal sac to nasolacrimal system, and from there actually to the systemic circulation bypassing the liver. And sometimes actually the drug passes on to iris and also ciliary body, and from iris to ciliary body it goes into the systemic circulation. So the cornea, the lipid content of the epithelium and endothelium is about 100 times more than that of the stroma. And therefore, it allows lipophilic than hydrophilic substances through it. Okay, because of the dual nature of corneal barriers, drugs possessing both lipid and water solubility, they penetrate the cornea more readily, and it causes more of concentration of the drug. Okay. So drug concentration and solubility. The higher the concentration of the drug, the better is its penetration. Pilocarpine, which we use actually as an anti-glaucoma medication, it's available actually in the concentrations of 1 to 4%. So the higher the concentration, naturally the higher the availability of the drug after its penetration. But the availability of this actually is limited by reflex tearing. Viscosity, if the viscosity is small, then the duration of action, the contact of the particular drug is more, and naturally it increases the drug penetration by increasing the contact time. Okay. Lipid solubility, higher the lipid solubility, the more the penetration of the drug through cornea. Surfactants such as benzyl conium and thiomersal, these preservatives used in ocular preparations, they alter the cell membrane in the cornea and increase the drug permeability. pH, the normal pH is around 7.4, and if the drug pH is much different, this will cause reflex tear. Drug tonicity, when an alkaloid drug is put in a relatively alkaloid medium, the proportion of the unchased form will increase, thus more penetration will occur. So ocular drug delivery, how actually the drugs are delivered. So first and foremost, we have actually eye drops. One drop is equivalent to around 50 microliters. So 1 ml contains nearly about 15 to 20 drops. So volume of conjunctival cul-de-sac after drug instillation is around 7 to 10 microliters. Hence, only about 20% to 30% of the drop instilled will get retained actually into the conjunctival cul-de-sac. The rest comes out. So that's the reason whenever actually any patient asks you how many drops actually you should instill it, only single drop will definitely suffice, not more than that, because about 2/3 of the drop it comes out of the eye. Only 1/3 actually gets retained in the conjunctival cul-de-sac. The topical medications are used as solutions, suspensions, and also ointments. So ointments, they increase actually the contact time with the ocular medication to the ocular tissues, and thus it will have actually better effect. So, but the problem is whenever you put in an ointment, it causes actually blurring of the vision. Hence, the ointments mostly we advise them actually to be applied in the night time. Okay, the drug has to be high lipid soluble with some water solubility to have maximum effect as ointment. So periocular injections, they bypass actually the conjunctiva and corneal epithelial barrier. And there are different types of periocular injections such as subconjunctival injections, subtenon, posterior subtenon, retrobulbar injections, peribulbar injections. They allow the medication actually to be effective behind the lens and the diaphragm. And they are useful for drugs with low lipid solubility. Higher lipid solubility, the penetration through the cornea will be more. Low lipid solubility, the penetration will be less, and hence these things can be given as periocular injections. Retrobulbar and peribulbar techniques, I think we have already covered by talking about the cataract and other intraocular surgeries. And intraocular injections, either it can be intracameral or intravitreal. Intracameral injections, especially we use them while doing the cataract surgery, and antibiotic can be given. And suppose if the pupil has come constricted, in such cases actually we can give intracameral adrenaline to dilate the pupil and to finish the surgery. And in case if there is actually a PC rent, and we have to place actually an ACI wire, in such cases intracameral echotypate or pilocarpine can be given to constrict the pupil. Okay. So antibiotics, mydriatics, and meiosis, all these things can be given. And intravitreal injections in case of diabetic macular edema, CRVO, and retinal surgeries, intravascular Avastin or Lucentin, all this can be given, or long-acting steroids can also be given intravitreally. Intraocular implants such as ganciclovir for CMV retinitis can be given. Reticet, fluocinolone for posterior uveitis can also be given. I think it is time for you people to have your lunch. And next class on Wednesday, I think we'll go on to the systemic drugs. After we finish it, I think most likely if I finish it off on Wednesday, it's good enough. If I continue it on Thursday, the seminar will be either on Thursday or Monday next. Okay. So the people who were given the topics, please be prepared. We are going to actually give the seminars.